That's something that, if any of you are interested in taking that offer up, please try and grab me in the course of the day or after the conference.
Thanks, Nick. So I'd just like to start by saying that, that the roundtable I'm talking about was the result of collaboration of many people across multiple organisations, and particularly like just to acknowledge my colleagues from Southwestern Sydney Local Health District, as well as staff from the Education Centre Against Violence who are still there and have moved on. I'd also like to acknowledge that the roundtable took place on the land of the Cabral people of the Darug Nation and the Tharawal Nation, and pay my respects to elders past, present and emerging. The sovereignty of these lands was never ceded, and the land always was and always will be Aboriginal land. So today's topic, you know where you are, that you've come into a domestic and family violence discussion, but just I guess being aware that I will be talking about examples of violence, abuse and neglect, and this can be distressing. Please take care of yourself and of one another. And certainly if any concerns are raised by the content, please reach out to 1800-RESPECT. Thank you. That's better. Just out of interest, in terms of a show of hands, just to sort of work out who's in the audience, who actually works in the violence, abuse and neglect sector here? Awesome. Who works in brain injury services? Okay, it's kind of 50-50. And who has lived experience of brain injury? Thanks, Nick. Okay, so it's just good to kind of have a bit of an idea. So just to give some idea of the definitions of what I'll be talking about. So I am talking about acquired brain injury in the context of domestic and family violence. And this includes the potentially lethal and long-term consequences, as Eve was just talking about, in terms of repeated exposure to physical assaults to the head, face and neck, as well as non-fatal strangulation. That also includes suffocation and choking, and attempted drownings as well. And ultimately, these physical assaults potentially leading to either a traumatic brain injury or to an anoxic or hypoxic brain injury. I'm also using the term victim survivor, and that's to represent the women who are mostly impacted by acquired brain injury in the context of domestic and family violence, and also acknowledging the gendered nature of domestic and family violence. So there's been some critical work over the last decade, and I'd certainly like to start by taking my hat off to Nick and Brain Injury Australia, because they have been absolutely leaders in this field. And in terms of other brain injury services as well, in 2014 the Children's Hospital Westmead did a lot of work around the Shaken Baby project, and a lot of that work has been continued and was discussed yesterday in Demetra and Bill's presentation on abusive head trauma for children. Brain Injury Awareness Week in 2015, and also the conference topic was actually around domestic and family violence, as well as the research that Brain Injury Australia and Nick did with a consortium of people in 2017. I actually have the unique position of having a foot in both camps. So at the time of this roundtable in 2019, I'd actually been working as a social worker at Liverpool Brain Injury Rehab Unit, which is in southwestern Sydney. It's one of the metropolitan brain injury units. And I worked as a social worker in the community team there. And I guess I certainly was aware of quite a few women that we saw who were on the moderate to severe end of brain injury, so had been hit in the head by hammers, shot in the head. And I knew that I guess we saw that more significant end in terms of the brain injury rehab services, but I also, with the research that Brain Injury Australia and other, I guess, discussions that were happening, knew that there were women and children that were presenting to domestic and family violence services that potentially had brain injuries, but that they weren't being picked up, and they certainly weren't receiving intervention for them. So while I was still at Liverpool, I spent some time going and running some training with some of the local domestic and family violence services around this is what someone might present like if they have a brain injury, and this is what you might need to do to adapt your practice. So things like talking about giving extra reminders for appointments, you know, not calling someone non-compliant because they keep forgetting to turn up for their appointment. So just some general education and trying to raise awareness. But I have to say overall that I feel like the violence, abuse, neglect sector, which I've now moved into 2 years ago, actually are really embracing the need for them to actually have an increased awareness around this issue and a better response to what they need to do in terms of responding in a way that actually is going to support these women. So off the back of some of these key moments, it was in 2018 that a discussion happened between the Education Centre Against Violence and Green Valley Liverpool Domestic and Family Violence Service, that the idea for a roundtable or a forum that would be held in southwestern Sydney with a range of stakeholders across multiple sectors. So I guess what Eve was talking about, that everybody needs to know this and we all need to be on board. And I guess this is an example of the collaboration that can happen across sectors, and that's the main message I want to get across today, is that there needs to be better collaboration across our sectors. So in terms of who ECAV is and who Green Valley are, so the roundtable was a partnership between the two services. So Education Centre Against Violence is a New South Wales health service. We're a statewide service. We run training, education for New South Wales health workers around child protection, around domestic and family violence, around sexual assault. We also run some of the training in the state for the Men's Behaviour Change Network as well. And we also provide training to other government services as well as non-government services. And Green Valley Liverpool Domestic and Family Violence Service, or a domestic and family violence service based in southwestern Sydney, who provides services to adult children and young people who've experienced family violence in that region. So the roundtable itself was held on the 20th of August in 2019. So originally it was only a year when the conference was happening that I was going to be presenting this. So a lot of time's passed since then. There were 80 attendees. Really importantly, that included victim survivors. And I guess that's one of the biggest messages I think that's been coming through at this conference, is the importance of actually including the people who access and use these services, and they need to be at the centre of everything that we do. The roundtable format's kind of different from a conference or a forum in that there's actually targeted invitations sent out. So people were actually invited, particularly because of their unique or expert knowledge and experience. There was a range of presentations, including Nick, panel discussions, small group discussions, and case studies as well. And overall, our whole idea was what Eve was just saying, which is to share information and raise awareness about acquired brain injury amongst a whole range of southwest Sydney services. But also to talk about, crucially, what are the potential pathways for the provision of both acute responses, but also those long-term support pathways for women and children who are turning up to domestic and family violence services, having never had a conversation about brain injury before. I guess what kind of, in terms of the, excuse me, in terms of the issues that came up, a lot of them are similar to what Eve mentioned, but also those of you that attended Rachel's pre-conference workshop as well. One of the biggest issues is that we call brain injuries the invisible injury, but they're even more invisible in the context of domestic and family violence. As Eve mentioned, women often don't attend and get medical attention following having an assault, or a strangulation to the, or assault to the head. And even if they did present, often it might be because there's another more obvious injury that they might have sustained. And unless there's an exploration at that point around, has there been a history recently or in the past of multiple blows to your head or strangulation, and that more deeper questioning around, and what happened, did you black out, can you remember what happened, those sorts of questions, then brain injury doesn't actually even get on the radar. So there was certainly discussion about the fact that this lack of medical response then means that there are many women walking around with undiagnosed brain injuries, or they're given another diagnosis, so assumed to have drug and alcohol related issues or have mental health issues that aren't actually necessarily the case. And it's this lack of medical response, I guess, as well, and I guess the other additional problem is that there's a lot of stigma and shame attached to disclosing histories of domestic and family violence, so that's also a barrier in terms of that was identified as a barrier to actually, finding out what had happened to a woman. Overall, the impact of this is that these women are falling through the cracks. They're not getting any intervention medically, they're not getting access to potential rehab and recovery that they would get at a crucial point. And potentially they're also going on to continue to have further brain injuries. It was acknowledged as well that not necessarily every single woman that presented to a domestic and family violence service with a history of blows to the head or strangulation necessarily has an acquired brain injury, but that it can be difficult as well to discern because symptoms of trauma can present very similarly, which is a lot of what Rachel spoke about at the pre-workshop as well. But ultimately, what's concerning is that without this assessment or without this diagnosis, we know that that repeated severe assaults to the head and neck actually pose a lethal risk for victim survivors. And there is plenty of evidence to show that perpetration of non-fatal strangulation or suffocation and blunt force trauma to the head in the context of domestic and family violence is actually strongly associated with being a stepping stone to homicide. So these issues, I guess, were particularly highlighted by some data that Green Valley Liverpool themselves had collected over an 11-month period, and they presented this at the roundtable. So as a service, their workers had heard women presenting who were saying things like, I've got headaches all the time that aren't going away. I've got cognitive impacts like I'm feeling really fuzzy in my head or having memory loss. So they were presenting with these symptoms, and so they started to collect some data. So they asked 156 victim survivors over an 11-month period whether or not they had experience of blows to the head, face or neck, whether they had experience of strangulation or suffocation, and also whether or not, crucially, they'd actually accessed medical intervention following these. So 89% of them, I guess similar to the stats that Eve showed, reported having experienced physical abuse. 54% had experienced suffocation or strangulation. But out of those number, only 21% had actually sought some sort of medical intervention. 10% of those had gone to their GP, and I guess as you would know, GPs, it's very hit and miss, so you would need to have a GP that actually had their head around not just domestic and family violence, but also around brain injury. 7% had presented to hospital, and 4% had been to both. Out of those who'd been strangled or suffocated, 29, so slightly higher, 29% had sought medical attention. And as part, I guess, of trying to change their practice, what Green Valley Liverpool Domestic Violence did is started to incorporate into their psychosocial assessments more questions about women's experiences of violence in their past, the actual context of what happened to them. So overall, I guess this data and the recommendations that came out of the roundtable were that there needs to be a better response. We need to actually be across sectors, having a greater awareness of an attention to the serial, so the repeated and cumulative neurological trauma that's happening in victim survivors. We need to have better collaboration between domestic and family violence services, between acute medical services if women are presenting to ED, but also, importantly, with brain injury rehab services who do see the more extreme end, but have all this wealth of knowledge and expertise that isn't necessarily being shared across the sectors. Part of this is about investing in workforce capacity and working in an education and training organisation. I guess that's my hope, is to continue to keep increasing awareness in the domestic and family violence service sectors and the health sectors around this particular issue, so that we can better identify, we can better respond, and potentially also prevent the prospect of acquired brain injury in the domestic and family violence context. There's been a lot of discussion, as Nick knows, around the importance of having screening questions and standardised screening questions. It's hard, and in New South Wales Health we have 15 local health districts that all do things quite differently, so trying to actually come at it from a statewide perspective or even a national perspective around how do we actually embed questions into screening questions into domestic and family violence services that will actually pick up the potential for a brain injury as well. There was a recommendation as well for there to be a qualitative research project taken. COVID's had a bit of a blow to that proceeding, but I'm hopeful that that's going to get off the ground now. There was a particular recommendation from the roundtable around there being focus groups with First Nations women and also with migrant and refugee women, given the demographics of the southwest Sydney area. I guess overall, this roundtable is an example of the fact that there can be collaboration across sectors. And whilst I feel that the violence, abuse and neglect sector are really embracing the need for them to increase their awareness and their responses, I still think that there is currently huge gaps in terms of there's no clear or consistent medical pathways for either the violence, abuse and neglect sector workers to access in terms of getting information and support for the women that they're seeing. I guess it's here that I see the potential for the brain injury rehab services, with the amount of knowledge and expertise that they have, to be able to provide more of a consultation and so that a collaborative response can be given, because these victim survivors essentially are falling through the cracks. Thank you.
Thanks, Robina. Are there any urgent, immediate questions for Robina before we continue? As I said, I'm going to be ruthless with my timekeeping so that we have a dedicated 5 and 10 minutes at the end for Q&A. I might just take the absence of an immediate question to editorialise for one moment. I think the perhaps the glaring omission in the ongoing white-hot conversation around domestic and family violence in this country is a lack of accountancy for the differential risk exposure of Aboriginal and Torres Strait Islander women to domestic and family violence, which is why it's wonderful that we have today Professor Marcia Langton, AO, and Dr. Kristen Smith from the University of Melbourne to present to us. Please welcome them both.
Just wait for the slides to come up and Marcia's face to pop on the screen for us.
Thanks very much for having us at this very important conference. So on behalf of Kristen and myself and our team here in Melbourne, we acknowledge the Gadigal peoples of the Eora Nation, the traditional owners and custodians of the lands where the conference is being held, and we pay our respects to the elders past, present and emerging, and similarly for the Wurundjeri Woiwurrung people of Naarm, here where I am. So we are presenting today on the role of brain injury and family violence for Aboriginal and Torres Strait Islander people. It's important that we warn you that some of the material in this presentation is confronting and disturbing and may cause sadness, distress or trigger traumatic memories for people, particularly survivors of past abuse, violence or childhood trauma. Support is available from Find and Connect support services, Lifeline, 1800 RESPECT, and of course, as previous speakers have reminded us, you should take care of yourself. So our work has been ongoing for many years, and during the course of our work, the Closing the Gap target finally involved a target on safety. So Closing the Gap target 13, families and households are safe. The outcome would be that Aboriginal and Torres Strait Islander families and households are safe. The target is that by 2031, the rate of all forms of family violence and abuse against Aboriginal and Torres Strait Islander women and children is reduced at least by 50% as progress towards zero. As you all know, extremely unlikely. So family violence is experienced by Aboriginal and Torres Strait Islander people and is associated with complex historical, cultural, social, legal and policy issues. And the problem is that we know very little about the potential significance of acquired brain injury for Aboriginal and Torres Strait Islander victims of perpetrators of violence. So Kristen has looked at the data and not only the qualitative data from our research projects, but also other available data. And so, for instance, we should remind you about family violence in Australia. The figures are alarming. Speakers have already spoken about it. 1 in 6 women in Australia have experienced physical or sexual violence by a partner since age 15. 4,600 women and 1,700 men were hospitalised in 2016-17 due to family violence. 63% of partner assaults leading to hospitalisation were for head injuries, neck injuries, including brain injuries. 1 woman is murdered every 9 days by a current or former partner. Approximately 10 women a day are hospitalised for assault by a partner. Intimate partner violence is the third greatest health factor for women aged 25 to 44. Family violence is the leading cause of homelessness for women. Mental health conditions are the largest contributor to the disease burden from partner violence. 1 in 4 women have experienced emotional violence by a partner since age 15. So that's the national picture. Let's now look at the Aboriginal and Torres Strait Islander data on family violence. There's extensive evidence demonstrating that family violence occurs at significantly higher rates in the Aboriginal and Torres Strait Islander populations than for the rest of the Australian population. There are increased risk factors for family violence, such as social stresses, including poor housing and overcrowding, financial difficulties and unemployment. 2 in 5 Aboriginal and Torres Strait Islander homicide victims, 41% or 32 victims, were killed by a current or previous partner, compared with 1 in 5 non-Indigenous victims. Although it is difficult to quantify, there appears to have been an even greater spike in violence against Aboriginal and Torres Strait Islander women and children during the COVID-19 pandemic in both frequency and severity. Family violence occurs at higher rates in the Aboriginal and Torres Strait Islander communities than in the general population. So Aboriginal and Torres Strait Islander people are 32 times more likely to be hospitalised for family violence than other Australians, and 2 in 3 physical assaults on Aboriginal and Torres Strait Islander women are perpetrated by a family member. This is what we know about acquired brain injury amongst Aboriginal and Torres Strait Islander peoples. In Western Australia, the Northern Territory and South Australia, Aboriginal and Torres Strait people are 20 times more likely to be admitted to hospital for a head injury. In North Queensland, traumatic brain injury is double the rate for Aboriginal and Torres Strait Islander people than for non-Indigenous Australians. In Perth, a study was conducted at the Banksia Detention Centre, and 9 out of 10 of the young people in that centre have a neurodevelopmental impairment, and 1 in 3 have fetal alcohol spectrum disorder. And of course, most of the young people in Banksia are Aboriginal. So even though the evidence is limited, most research has indicated higher levels of acquired brain injury within Indigenous populations and significantly higher rates of head injury in the Indigenous population than for other Australians. So I will hand over to Kristen to explain our research projects.
Thanks, Marcia. So I'm just going to tell you a little bit about the projects that we're drawing on today to let you know about some of the findings that we've made from them. So the 3 projects were looking specifically at Indigenous family violence, and they were conducted across 3 different case study sites across Australia. So the first study was conducted in the Wyndham East Kimberley region, of which Kununurra and Wyndham are the 2 major towns in that area. Up in northern Western Australia, you can see maybe the little dot here. It's probably a bit hard to see. We also conducted research in Mildura on the border of Victoria and New South Wales, and also in Albury-Wodonga in New South Wales and Victoria. So for all 3 of these projects, we employed mixed methods research, primarily using and relying on ethnographic approaches and methods. Really, we were looking at examining the pathways traversed by Aboriginal and Torres Strait Islander people across the family violence and justice service, or family violence justice and service system. So 2 of the projects focused specifically on Aboriginal women who had experienced family violence, and one of the projects looked at Aboriginal men who had perpetrated family violence. So for all 3 projects, we included thematic questions in the focus groups and interviews looking specifically at brain injury, and this was after several discussions that we'd had with Nick. As I mentioned, we did predominantly use ethnographic methods, which included semi-structured interviews, focus groups, and participant observation at each case study site. So across the 3 projects, we interviewed a total of 148 people across 48 individual interviews and 35 focus groups. And our participants included a wide variety of people, including Aboriginal people who had experienced or perpetrated family violence, Aboriginal elders and leaders, also Aboriginal community members, also a range of service providers, including health providers, court and legal services, Aboriginal community-controlled organisations, housing and homelessness services, and government agencies and officials. So as I mentioned, we also conducted participant observation during multiple fieldwork trips at each site, and were supported by local Aboriginal research assistants. Our research, particularly in the East Kimberley, is also informed by analysis of 10 years of Western Australia police data in the Wyndham East Kimberley region, and also data from the Kununurra Crisis Accommodation Centre. And we also analysed a range of relevant open access data for a variety of government sources and agencies. So the projects all have research ethics clearance from the University of Melbourne, and the East Kimberley research also has ethics clearance from the Western Australia Aboriginal Health Ethics Committee. So just as a note, in this presentation, any quotations or references to participants, they're not their real names, they're pseudonyms. So first I want to share some of our initial findings related to acquired brain injury and Aboriginal and Torres Strait Islander victims of family violence. So many of the service providers who provide support to women who are victims of family violence at the case study sites explained how they suspected that a large majority of their Aboriginal clients may have some form of brain injury acquired as a result of the family violence they had experienced. For example, Janine, an officer of the court, noted that this also makes women far more vulnerable to chronic victimisation. So they are not victims necessarily from one perpetrator, but it's something that happens again and again. Janine also explained, and we heard this from several service providers, that it often women with brain injury are at a higher risk of suffering more severe family violence. So other family violence service providers explained that many of their Aboriginal clients with acquired brain injury regularly have perpetrators that use coercion and manipulation to control them, and that Aboriginal and Torres Strait Islander women who are victims of family violence with acquired brain injury often remain undiagnosed or misdiagnosed, regardless of whether the symptoms can be identified by local healthcare and service providers. Some service providers in the study expressed the generally low levels of understanding of brain injury across workers in the family violence support service sector, and even if the workers did recognise the likelihood of brain injury in their clients, they were regularly frustrated by the inability to refer people to local specialists, such as neurologists or neuropsychologists, to obtain any sort of diagnosis, as the expertise required is often not accessible in these regional and remote locations. This really does represent a form of geographic healthcare inequity and disadvantage, as without these diagnoses, many women with brain injury have very little access to suitable forms of support services, including medical, allied health, and other related support services to assist them in their daily lives. Whether this is related to supporting them raise their children, for their rehabilitation or recovery services, or also general financial services. So then the other element that we wanted to look at, that we have some findings on, is looking at acquired brain injury for Aboriginal and Torres Strait Islander perpetrators of family violence. So as many of you may know, acquired brain injury can include damage to parts of the brain that regulate emotions and behaviour. So some Australian studies have found that people with acquired brain injury have a higher likelihood of committing violent crimes. So, for example, one study that analysed 10 years of data between 2006 and 2016, a Victorian Emergency Department hospital data found that male perpetrators of intimate partner violence are twice as likely to have sustained a brain injury as matched community samples, and that around 60% of these perpetrators had acquired brain injuries. There are also multiple studies that have connected high rates of acquired brain injury with intergenerational trauma, of which we often find in many Aboriginal and Torres Strait Islander communities. So Aboriginal and Torres Strait Islander people are 15 to 20 times more likely than non-Indigenous people to commit violent offences, with Aboriginal and Torres Strait Islander men significantly more likely to be charged with a violent offence. Aboriginal and Torres Strait Islander people are also significantly overrepresented in the criminal justice system, a trend that has increased over time, and particularly so for incidents of family violence. It's also critical to note here at this junction that family violence experienced by Aboriginal and Torres Strait Islander women is not exclusively nor necessarily linked to Aboriginal and Torres Strait Islander men, and not all perpetrators of violence against Aboriginal women are Aboriginal men. But however, within the context of the research that we've undertaken, it did focus on Aboriginal and Torres Strait Islander men who are perpetrators of family violence, rather than more broadly in the population. So at the 3 case study sites, the Aboriginal men who had perpetrated family violence were identified as having high rates of acquired brain injury. So for example, one service provider working with perpetrators of Aboriginal perpetrators of family violence noted that approximately half of the men he works with have acquired brain injuries from either drugs and alcohol misuse or physical violence, often inflicted on them in childhood. He also noted that he suspected that up to 90% of his clients, Aboriginal clients, may have acquired brain injuries, but most of those would not have been diagnosed. So several service providers also discussed with us and brought up the factor that many perpetrators they work with, who are perpetrators of family violence, often used violence as a form of communication. Other family violence support workers often discuss the unregulated and often aggressive behaviour of their Aboriginal clients who were perpetrators of violence as well. Now, our research findings indicate that although perpetrators of family violence with acquired brain injury often require medical supports, interventions and rehabilitation, their acquired brain injuries more often than not only identified after engagement with the criminal justice system. Further, even if the support service providers suspect perpetrators of family violence have acquired brain injuries, they're frustrated again, similarly to the victims, by the lack of specialised services available in the region to refer perpetrators of violence to in order to obtain diagnosis and the subsequent appropriate care. So other issues that were raised included the inability to recruit and retain suitably trained and experienced staff to appropriate services to work with Aboriginal people with acquired brain injury in both regional and remote locations. Further, there is really very little evidence to suggest that the primary support services available to men who perpetrate family violence, which are men's behavioural change programs, are adequate or appropriate. So the Victorian Royal Commission on Family Violence Summary and Recommendations report clearly states that there is insufficient knowledge to gauge whether men's behavioural change programs are effective in shifting perpetrator behaviours, nor is there enough evidence demonstrating that they improve victim safety. The report further notes that men's behavioural change programs are not designed for different cohorts and those unsuited to group work, which really leads us to this question of, their likely unsuitability of the standard men's behavioural change programs for Aboriginal and Torres Strait Islander men with acquired brain injury. So the other thing that we looked at in the context of the research across the 3 projects, and more specifically in the region of the East Kimberley, was looking at the role of alcohol in terms of both acquired brain injury and family violence for Aboriginal and Torres Strait Islander people. So alcohol consumption can lead to brain impairment due to its toxic effect on the central nervous system, impact on metabolism, obstruction of the body's ability to use vitamin B1, its dehydrating properties, which can lead to cell depletion and death, and also its association with poor diet and, importantly, its contribution to accidents that can lead to traumatic brain injury. So short-term high risk and longer-term high risk drinking patterns can lead to a wide range of social, health and economic problems for individuals and Aboriginal communities, including acquired brain injury. So harmful drinking patterns often develop when alcohol is relied on to manage underlying trauma and stress, including community-wide intergenerational trauma that we've already touched on briefly. There is also stronger evidence that demonstrates the relationship between alcohol and a range of different acquired brain injuries. So some of our participants also noted that acquired brain injury is often misinterpreted as drug or alcohol consumption by authorities during family violence call-outs. For example, one of our participants, Elaine, noted, but there's a lot of mental health issues there too, that police think maybe it's drugs or alcohol, but it's not, they're mental health, acquired brain injury or whatnot, is what she said. So this misidentification then makes it more likely that people with acquired brain injury end up in the criminal justice system, rather than enabling early preventative access to more appropriate medical or social supports. I'll pass back over to Marcia.
Thanks, Kristen. So as Kristen explained, we were able to obtain police data on for the Wyndham East Kimberley region for a 10-year period, 2009 to 2019, and our analysis of this data shows that 69% of offences against the person had alcohol involved or present. Alcohol was involved or present for 65% of breaches of violence orders. Alcohol was present or involved in 85% of serious family assaults. Present or involved in 73% of all assaults. And the rate of alcohol-related assaults was almost 2 times higher in 2019 than 2009, a decade previously. So the rate of alcohol-related assault had doubled in 10 years. Victims of alcohol-related offences constituted 71% of the population in this data set. So alcohol-related crime has significantly increased for the whole community in the Wyndham East Kimberley region in that decade, alongside offences with a domestic relationship between the parties. So offences against the person have a strong association with alcohol, and we put this down to the alcohol restrictions, the legal alcohol restrictions in the region, which are clearly not adequate to prevent the violence and assaults, as you can see, which have doubled in a decade. Back to you, Kristen.
Thanks, Marcia. I'm just realising we're going to have to wrap up shortly, but I'll go through the last couple of slides pretty quickly. So some of our findings in the East Kimberley related to fetal alcohol spectrum disorder. Initially, as you can tell from the quantitative data that Marcia's just spoken about, but also drawing on our qualitative data, community attitudes to harmful drinking across the East Kimberley are quite extreme. We also found that there is a very likely high prevalence of FASD in that community. As you can see from the slide here, that there are now 3 to 4 generations of FASD in some families. And also service providers, we're estimating that upwards of 60, maybe up to 80% of the Aboriginal children in that region may have FASD or present with symptoms of FASD. One of the big problems, as I've already spoken about, is the lack of availability of screening and diagnosis in that region, but it's also similar for other regional and remote places across Australia. So the primary means for children or adults to be diagnosed or screened for FASD is either when they get court orders, so going through the court systems when they've been charged, or for children when they go into the child protection system, which is a whole other story for another time. Also, if we're looking at alcohol, FASD and family violence, as we can see here from one of the legal service providers who had, well, one of the Aboriginal legal service providers, it just states that, you know, it's not just in the children, as I said, it's potentially up to 3 to 4 generations of people, so it's a significant issue. So the last thing that we really wanted to raise, I think I'm handing this back over to Marcia, is very quickly, is our concern about the removal and relaxation of alcohol policies and programs because of some of the research we've done in the Kimberley. Marcia.
In various parts of North Australia in the last month, at their request in some cases, there's a very high degree of concern about the expiry of the Stronger Futures legislation in the Northern Territory, and that will result in the removal of all alcohol restrictions on Aboriginal land and in those areas covered by alcohol management plans. The likely removal of the cashless debit card trial in the East Kimberley is feared because it will likely result in a huge increase in alcohol consumption with the availability of cash to spend at the alcohol takeaways. And also, we've been contacted about the plan to relax the alcohol management plans in Cape York and introduce or reintroduce licensed venues. Again, there's a huge amount of concern. And I'll go straight to the last slide, Kristen, about our key recommendations. So we recommend greater investment in AOD or alcohol and drug support services for Aboriginal and Torres Strait Islander people experiencing family violence. We recommend wider availability of acquired brain injury screening for victims and perpetrators of family violence. We recommend an evidence-based public health response or responses to Aboriginal and Torres Strait Islander perpetrators of family violence with acquired brain injuries. As we pointed out, they are too often criminalised, whereas in fact they require a range of health services and other services. We also note that there is an urgent need for more research on effective wraparound services and interventions for victims and perpetrators with ABI. And so we would like to thank the other members of our team at the Indigenous Studies Unit in the Centre for Health Equity at the University of Melbourne, particularly Talia Eastman, and remind you again that if any of this material has caused you distress, please contact one of the support services.
Thank you very much.
Thank you.